All right, if you're on the wards or in clinic, you're seeing COPD pretty much every single day. But here's the question. Are you managing it based on the absolute latest guidelines? Well, this is your high-yield explainer for stable COPD. We're going to break down that new ABE framework so you can nail the diagnosis and the initial treatment every single time.
So here's our game plan. We're going to walk through this just like you would with a real patient. First, how do we lock in the diagnosis? Then, how do we properly stage the disease? After that, we'll dive into the new ABE groups, which is a real game changer. Then the fun part, choosing the right initial meds. And we'll wrap it all up with the absolute must-know takeaways. Let's jump in.
Okay, first things first. Before we can treat COPD, we have to be sure that's what we're dealing with. We need to move beyond just the symptoms and get some objective proof.
We hear this all the time, right? Oh, it's just a smoker's cough. But listen, a chronic cough in someone with risk factors is not a diagnosis. COPD is a specific, treatable condition, and to do it right, we need concrete evidence. We can't just guess. The official definition tells you everything you need to know, but the most important part, the key phrase, is persistent airflow limitation. Persistent means it's not going away, and limitation is something we can and absolutely must measure. And here it is, the golden number. This is what you need to remember. To diagnose COPD, you have to use spirometry, and you're looking for one specific thing, the ratio of FEV1 to FVC. If that ratio is less than 0.70, after the patient uses a bronchodilator, you have your diagnosis. That post-bronchodilator piece is absolutely critical. It proves the obstruction isn't reversible, that it's fixed. And that is the hallmark of COPD. So what does this actually look like? It's pretty cool. On a flow volume loop, a healthy person blowing out air makes a nice, straight, downward slope. But in COPD, those small airways start to collapse when they try to force air out, which traps air and slows down the flow. This creates this classic scooped-out, kind of concave shape. When you see that scooped-out curve, your brain should immediately scream obstruction. So we've confirmed the diagnosis with spirometry. Awesome. Our next job is to stage it. And this isn't just about giving it a label. It's about really understanding the patient's disease so we can pick the right therapy.
Staging is really a two-step process. Think of it like this. First, we look at the numbers, the FEV1, to grade how severe the airflow limitation is on paper. But second, and this is actually more important for treatment, we assess how the disease is impacting the patient's life, their symptoms, and their risk for getting sick in the future. So, step 1 gives us the GOLD grades, 1 through 4. This is based purely on that FEV1% predicted value. You've got GOLD 1 for mild disease, all the way down to GOLD 4 for very severe disease. Now, this grading system is actually a really good predictor of long-term mortality risk. And this, right here, is probably the most important point of this whole explainer. The FEV1 grade, that GOLD 1 through 4, tells us about the patient's prognosis, but it's a terrible guide for choosing their first inhaler. For that, we have to turn to the second part of staging, the ABE assessment, which is all about how the patient is actually feeling and doing day to day.
So let's build out this new framework. The ABE classification is the modern way we connect how our patient presents directly to our treatment plan. It's super practical.
Okay, let's sketch this out. We start with a simple grid. The horizontal axis, the x-axis, is all about the patient's symptom burden. We usually use the MRC dyspnea scale for this. A score of 0 or 1 means fewer symptoms, while a score of 2 or more means they're having significant, life-limiting breathlessness. Then the vertical y-axis tracks their history of exacerbations over the last year. Now, we draw our lines to divide the grid. That vertical line separates low symptoms from high symptoms, right at that MMRC score of 2. The horizontal line separates low risk from high risk. What's low risk? That's 0 or maybe 1 flare-up in the past year, as long as they didn't end up in the hospital. High risk is anyone who's had 2 or more of those moderate flare-ups or, and this is key, just a single exacerbation that was bad enough to land them in the hospital.
And this is where it all comes together. The bottom left box is Group A. These are our patients with low symptoms and low risk. The bottom right is Group B. These folks have high symptoms, but they're still at low risk for exacerbations. Now, here's the biggest change from the old guidelines. The entire top row is now just called Group E. E for exacerbator. This is huge. It means if a patient is at high risk for flare-ups, we don't even care about their daily symptoms for this initial classification. That high risk alone puts them in this special high priority category.
All right, now that we've correctly classified our patient, we can finally choose the right initial therapy. This is where that ABE system really pays off. So for a patient in Group A, remember, low symptoms, low risk, we start simple. A single long-acting bronchodilator. That could be a LAMA, a long-acting muscarinic antagonist, or a LABA, a long-acting beta agonist. Either one is a perfectly good starting point.
Now, for a Group B patient, their big problem is symptoms, right? They're breathless, they feel bad. So they're going to benefit from more powerful bronchodilation right from the get-go. So for them, we start with dual therapy, a LAMA plus a LABA, usually in a single combination inhaler.
And for our high-risk Group E patients, the top priority is preventing those dangerous future exacerbations. The foundation, the starting point for them, is also dual therapy with a LAMA and a LABA. But for this group, we have to ask one more very important question before we write the script. And here's the pearl. For your Group E patients, you need to check their blood work, specifically their eosinophil count. If that count is elevated and the magic number is 300 cells per microliter or higher, it's very reasonable to go straight to triple therapy, a LAMA, a LABA, and an inhaled corticosteroid, or ICS. This is a great example of using a biomarker to personalize therapy for the patients most likely to benefit. This brings us to an absolutely critical, can't-miss clinical pitfall. In asthma, as you know, inhaled steroids are the foundation of treatment. But in COPD, you should never, ever use an inhaled corticosteroid by itself. ICS monotherapy just doesn't work well, and even worse, it's been shown to increase the risk of pneumonia. Remember, in COPD, steroids are only an add-on to bronchodilators and only for certain high-risk patients. All right, let's bring it all home. We're going to summarize the most important high-yield points that you absolutely need to take with you to the clinic and, of course, for your exams. Let's lock these 5 points in. 1. Diagnosis is confirmed with that post-bronchodilator FEV1 to FVC ratio being less than 0.70. 2. Use the ABE grid based on symptoms and exacerbations to guide your therapy, not the FEV1 grade. 3. Remember, Group E is the new bucket for anyone at high risk of exacerbations. 4. The foundation of therapy for almost everyone who is symptomatic is dual bronchodilation with a LAMA and LABA. And 5. The big pitfall. Never, ever use an inhaled steroid by itself in COPD. And that's our deep dive into managing stable COPD. So the next time you see a patient with COPD on your list, I want you to ask yourself this question. Now that you have this framework, is their current therapy actually aligned with these modern evidence-based ABE guidelines? Because applying this knowledge is exactly how we give our patients the best possible care.